Assalamu alaikum and a very good morning, all of you. I am Dr. Rabia Shah, ID Fellow Year 2, and I welcome you all on the behalf of the Department of Infectious Diseases, the Indus Hospital and Health Network today to this very interesting session of ID in our Icon of 2022. We'll be here with you for the next 2 hours, and there are some very exciting talks lined up from ID physicians from across the globe. We'll have a 10-minute sessions of question and answers at the end of our discussion, and I request you all that if you have any questions, then you just drop them down in the chat box, and we'll note down the questions. And I'd also announce that in order to get the CME certificates, you all are requested to please fill the feedback forms. Session today is chaired by Dr. Sumaya Nizamuddin. She is trained at Al Khan University Hospital. She's FCPS Microbiology, section head of the Department of Microbiology in Shaukat Khanum Memorial Cancer Hospital and Research Center in Lahore. She has served as the General Secretary of MMIDSP for 2 terms. Our co-chair for today is Dr. Azizullah Dhillu. He is the FCPS Infectious Diseases, currently working as an assistant professor at Dow University of Health Sciences, Civil Hospital, Karachi. Welcome, Dr. Sumaya and Dr. Aziz. Thank you so much for joining us. Without any further delays, let's start off with the very first talk for today. That is Battle with Microbes, Depleting Arsenal by Dr. Aamir Qazi. Dr. Aamir, MD, MBBS, he has graduated from Al Khan University Hospital, Pakistan in 2014. He completed his internal medicine residency from St. Louis University Hospital in 2018 and infectious diseases fellowship from Rush University Medical Center in 2020. This was followed by a transplant infectious diseases fellowship at the UT Health McGovern Medical School in Houston, with experience in infections of solid organ and bone marrow transplant recipients. He has joined the division of ID at the Indus Hospital in 2021. His main interests are infections in transplant recipients and immunocompromised hosts, antimicrobial stewardship, and invasive fungal infections. Current research projects including assessing implementation of steward recommendations. So, starting off with the talk, over to you, Dr. Aamir.
So our first case here is going to be about azole-resistant Aspergillus fumigatus. I have no I'm an infectious disease consultant at the Indus Hospital and Health Network. We have with us today Dr. Hasbun, who is a professor and faculty of infectious diseases and transplant infectious diseases at the McGovern Medical School at UT Houston. He is a world expert on CNS infections, has received multiple grants for studying meningitis, encephalitis, HIV-associated neurocognitive disorders, West Nile virus, has been a panel member for the first healthcare-associated ventriculitis and meningitis guideline, and has published multiple book chapters on meningitis and encephalitis. So we'll get started with our case. Case of CME resistance. I have no financial interests or relationships to disclose. Chief complaint for this case was 3 weeks of fevers, dry cough, and watery diarrhea. This was a 69-year-old female with a prior history of congestive heart failure and end-stage renal disease secondary to hypertension and diabetes, systemic scleroderma complicated by interstitial lung disease requiring a bilateral lung transplant in August 2020, had received basiliximab and solumedrol for induction therapy, was CMV D plus R minus, so high risk for CMV reactivation, had been on infection prophylaxis with itraconazole due to a pre-transplant positive coccidioides serology, TMP SMX, and valganciclovir. Current immunosuppression was with tacrolimus, MMF, and prednisone. The post-transplant course had been, in the early post-transplant course, had been complicated by bilateral bronchial stenosis requiring bilateral stent placement that was subsequently removed and had post-transplant Pseudomonas pneumonia treated with cefepime. Regarding the presenting complaints, she'd had 3 weeks of fever, dry cough, and watery diarrhea, which had been not responsive to courses of levofloxacin and azithromycin, had tested negative for COVID-19 and other respiratory viruses by PCR. At the time of admission, this is what her CT chest showed: bilateral ground glass opacities throughout all lung zones. Regarding the timeline of CMV for this patient, prior to admission, at day -7 prior to admission, the patient's labs revealed cytopenias, white counts as low as 2.1, was lymphopenic as well, only about 5 to 10% lymphocytes, anemia, which was new, 9.6, and platelets, which downtrended. A serum CMV PCR prior to admission was of 36,000 copies, was prescribed, was appropriately prescribed, appropriately dosed valganciclovir prophylaxis. There were questions regarding the patient's adherence. This was the standard prophylaxis with valganciclovir, universal prophylaxis, since the patient was CMV D plus R minus. A week prior to admission, when these labs were noted and the CMV PCR was positive, the prophylaxis dose valganciclovir was switched to induction dose valganciclovir. Despite that, with dropping cell counts, with pancytopenia, which was new, and fairly high CMV PCR still, the patient was admitted and received induction dose IV ganciclovir. Despite getting ganciclovir for a week, had suboptimal response, both in terms of the cytopenias and the CMV PCR, and then was empirically switched to IV foscarnet. There was concern for resistance, so a CMV genotype was sent. The patient's cell counts and CMV PCR both responded well to the IV foscarnet. This is what the CMV genotype revealed: a UL54 mutation for cidofovir and ganciclovir with resistance at the site P488R. A UL97 mutation was not detected, and no mutation to foscarnet was detected. And so for this case of disseminated CMV with a UL54 mutation, the patient underwent a bronch BAL that was positive for CMV PCR. Biopsy was negative for rejection. Additional workup was negative for PJP and respiratory viruses. A bone marrow biopsy was normocellular and had positive CMV immunostaining. The patient received renally dosed foscarnet induction for 3 weeks, followed by maintenance therapy for 3 months with foscarnet. This resulted in resolution of the fever, the cytopenias, diarrhea, and cough, along with virologic suppression. So we're going to get Dr. Hasbun's help with these discussion points. Number one, when should ganciclovir resistance be suspected and its risk factors? Comments on the diagnosis of CMV resistance and genotype interpretation, comments on cross-resistance and codons, and treatment strategies for both the UL97 and UL54 resistance. Thank you, Dr. Hasbun. Handing over to you.
Okay. Hello, Aamir. Can you hear me? Yes, Dr. Aspen, good evening at your end and good morning at ours. Thank you so
Yeah,
much once again for joining us.
thank you for the invitation. So it's a pleasure to discuss the case. Um, so first, I just want to talk about CMV seropositivity, viremia, and end organ damage in different scenarios. As you can see in solid organ transplant, you can either have a donor positive, recipient positive, or a donor negative, recipient positive, or a donor negative and recipient negative, or the donor positive, recipient negative. As you can see in the chart below, the donor positive, recipient negative in the solid organ transplant is the highest risk. So if you don't do any prophylaxis or preemptive therapy in that group, up to 80% are going to have CNV, viremia, or end organ damage. In contrast to the stem cell population, the recipient positive is the one at highest risk. As you can see here, up to 80% of them are going to have viremia or end organ damage. The other ones are going to be much lower incidence of viremia and end organ damage. So it's very important to try to prevent this after a solid organ or a bone marrow transplantation procedure. So there's typically two types of ways to prevent CNV infection. There's a prophylaxis where you can give,
Dr. Aspen,
yes,
I'm so sorry to interrupt. I think we're not able to see your shared screen. Are you sharing your PowerPoint with us?
yes, I should. Sorry about that. Let me see if I did it right. Upload. Let's see if we can. See if I can. Sorry about that.
No worries, no worries.
Are you seeing them now or no?
Not seeing your shared screen. We're able to see you and hear you.
Okay. Browser can't access your screen. Try capturing a different screen. Oh, okay. Can you see it now?
We can see both your slides and you now.
Okay. Is it a good size or do you?
I'm sorry.
Is it in a good size?
Yes, it's perfect. It's
Perfect.
perfect.
Okay. Sorry about
Thank you.
that. Okay.
No
Now we
worries.
can start with this. So this is the chart that I was referring to, where you can see basically the degree of you know, CNV viremia and end organ damage by the type of transplant. So in the solid organ transplant, those that are donor positive, recipient negative have an 80% chance of having viremia or end organ damage. In contrast, the stem cell population, those that are recipient positive are going to have up to 80% viremia or end organ damage. So those are really the two high risk groups in the stem cell and the solid organ. So we definitely want to prevent this from happening in patients with solid organs and stem cell transplants. So the two ways to do this, either giving prophylaxis or doing a preemptive approach. So in the solid organ transplant population, it's commonly done to give just prophylaxis. For this, there's large evidence of evidence, and it's really easier just to give a prescription than preemptive. Preemptive, you need to be checking their CNV viral loads every week, and if they're positive, then treat. Um, the the advantages of prophylaxis is that you can prevent CNV infection, disease, and the indirect effects of CNV, like on graft loss, like rejection. But the problems with prophylaxis is that obviously there's a high cost to it, and you have side effects from the prophylaxis, like anemia and neutropenia, especially with valganciclovir. The preemptive therapy will definitely treat the CNV viremia, but we're very familiar that a lot of our patients can have end organ damage without viremia. So you're not going to prevent the CNV, gastritis, and colitis in those patients. In contrast, in the stem cell population, it's more common to do preemptive therapy because in the bone marrow transplant patient, we try to avoid medications that lower the white count and the hemoglobin to prevent anemia and neutropenia from valsite. So you're going to see more preemptive therapy where they're going to be checking a CNV PCR. Obviously, they have to come to the lab. You need to be following on that. So it's going to be more of a hassle, but that's what's done more commonly in the stem cell population. So when we're treating for CNV disease, we need to worry about refractory or resistant CNV. So refractory CNV is when you have viremia that is increasing by more than a log after being on 2 weeks of appropriate therapy. So that's called refractory. Drug resistant is when you have a CNV genotype that documents that there's a mutation that confers resistance to the antiviral medications that we typically use. And a lot of the risk factors for refractory or resistant CNV are going to be prolonged antiviral therapy. If there's, patients not taking their medications well, there's decreased absorption of the valsite. The type of transplant is very important. The type of immunosuppressive therapy is very important. And we'll go through those risk factors for both patient populations. So for the solid organ transplant population, we already mentioned that the highest risk group is a donor positive, recipient negative. And when you're looking at the type of transplant, lung transplant like this patient and pancreas and small bowel transplant are the highest risk. So this patient that Aamir presented was donor positive, recipient negative, was a lung transplant. So she's already, at high risk. She did get basiliximab instead of alemtuzumab. So alemtuzumab and ATG are higher risk for CNV reactivation and than basiliximab. And then the type of maintenance immunosuppression is very important as well. As you can see, mTOR inhibitors like sirolimus or everolimus have low incidence of having CNV infection. But we don't use sirolimus a lot. We use more tacrolimus and steroids and mycophenolate that have a high chance of having CNV reactivation, because sirolimus is also associated with poor wound healing, and a lot of our surgeons don't like to use sirolimus for that reason. So for stem cells, there are risk factors depending on the timing of that CNV infection. So if you get a CNV infection in the first 30 days after transplantation, again, being CNV seropositive is one of the biggest risk factors. Advanced age, the type of transplant similar to solid organ in stem cell transplants, the match unrelated donor or the cord blood transplant or haploidentical transplant are going to be a higher risk. And also what type of condition and regimen they got. So they got fludarabine or ATG or alemtuzumab, just like in our solid organ transplants, they're going to be at higher risk. Then for those patients that develop CNV infection 30 days to 100 days after, the presence of GVHD is a very important risk factor, and a delay of the T cell recovery. And then in late onset CNV infections of over 100 days, the use of steroids, GVHD, delay of T cell recovery, non-myeloablative conditioning, and CNV reactivation before the 100 days are also the most important risk factors for developing CNV infection. So it's very important, the ganciclovir-resistant CNV, because it impacts your outcomes. In this study, we clearly see that it's associated with mortality. And in this study with kidney transplants was also associated with rejection. So it's a very important entity to identify for our patients. There are several genes. The UL97 gene targets the kinase, and resistance in that gene could confer resistance to ganciclovir, valganciclovir, and even the new maribavir that's just got FDA approved in November. The UL54 gene targets the polymerase, and you can have, depending on the codon that's affected, you can have resistance to all the antiretrovirals like ganciclovir, valganciclovir, cidofovir, foscarnet, or even brincidofovir. UL27 targets the cell cycle regulation, and that's going to give you low-level maribavir resistance. And then the UL51, 56, and the UL89 are targeting the cleavage and the packaging of the virus seen with letermovir resistance. So all the approved antiviral agents for CNV have already have mutations that can make them ineffective in our patient population. And it's not only the genes, but also all the different codons associated that really are important, because some are going to be in, like in the UL54, you can see all those codons are going to give you resistance to either ganciclovir, cidofovir, or even foscarnet. In the UL97 are really targeting ganciclovir. The UL56 is really targeting letermovir, and the UL89 as well letermovir. So the UL54 is very important because there's a lot of different mutations that can confer resistance to different antivirals, like in this case, that was resistant to ganciclovir and resistant to cidofovir. So again, some mutations can, in the UL54, can confer resistance to ganciclovir and cidofovir, like in this patient, or to ganciclovir and foscarnet, or to all antivirals. So pan-resistant to ganciclovir, foscarnet, and cidofovir. Obviously, for this, we still have letermovir and maribavir that we can use for the triple drug-resistant isolates. So the typical antiviral medications that we use are valganciclovir, that can be given orally, and you can induce somebody with oral valganciclovir, highly bioavailable antiviral. IV ganciclovir, Valtrex, that's really not recommended unless for kidney recipients, kidney transplant patients. Foscarnet, that has to be given intravenously and has nephrotoxicity. So you gotta be careful and monitor their creatinine and their magnesium and phosphorus. And cidofovir can also be nephrotoxic. So if you're treating somebody with a renal transplant with AKI, and you have a ganciclovir resistant mutant, can sometimes be tricky to treat them with foscarnet or cidofovir because they can worsen their kidney function. So there are a new kids in the block. Letermovir is one of them that we've been using. It inhibits the terminase complex subunit in UL56. If you're going to switch somebody to letermovir, you need to know that it doesn't have activity against HSV. So like all the other antivirals like valganciclovir, foscarnet, they have activity against other herpes viruses. In this case, if you switch somebody to letermovir, you got to put them on Valtrex to prevent HSV as well. They're highly bioavailable drugs, excreted mostly in feces, and the dosing is 480 milligrams daily, unless you're giving it with cyclosporin that you have to give a lower dose. The main side effects are going to be GI. There's a lot of drug interactions with the new medications like letermovir and maribavir, and it's really only approved for prophylaxis, not for treatment. So this is only for prophylaxis. If you have somebody with a detectable viral load or active disease, that's not really indicated for that. The latest antiviral to be approved that we are trying to get a hold of right now in our hospitals is maribavir. So this has been used for not only prevention, but also treatment of ganciclovir-resistant CNV. So in this study, it was shown in the bone marrow transplant patients to be as effective as Valcite or valganciclovir to prevent CNV disease. And it's again very bioavailable, just like letermovir, and it blocks the nuclear aggressive viral capsids through the inhibition of the protein kinase UL97. So this can be used for a mutant that's ganciclovir, foscarnet, cidofovir resistant. In the latest study, just published in CID in December of this year, this is a randomized clinical trial that enrolled patients with refractory CNV infections with or without resistance, and they gave 400 milligrams twice daily for 8 weeks, and they compared to investigator-assigned therapy for 8 weeks, and then they looked at outcomes 12 weeks later. As you can see, there was a mix of solid organ transplant patients, 60% solid organs, 40% bone marrow transplant patients, and the primary endpoint was much better with Maribavir, 55% versus 23%, looking at clearance of CNV viremia with the drug. So it's a great drug. Unfortunately, it's also very expensive. So I just learned today that it's going to be $900 a day to use this treatment. So even though it's very highly effective, I think we're going to be using it for patients that are really triply resistant to all the other antiretrovirals, or we have really dose-limiting toxicities like kidney failure or severe anemia and neutropenia because of the cost, unfortunately. And just to finalize, there's other things that can be done for refractory or resistant CNV. You can do CNV IgG, or you can do adaptive infusions of CNV-specific T cells. You can switch the maintenance from tacrolimus to sirolimus or everolimus, because those mTOR inhibitors are less likely to be associated with CNV reactivation. Leflunomide has been used in case reports and case series, but there's no clinical trial evidence, but it has been used as a salvage regimen. And also artesunates have also been used in small case reports, but again, no clinical trial data. So thank you very much. If there's any questions, I'll be happy to answer them right now.
Thank you so much, Dr. Hasbun, for that expert talk. We appreciate you joining in and for all your time.
Yeah.
We are going to be saving our questions right for the end of the session.
Okay.
And so at this point in time, we'll move on to our second case.
Okay.
And so thank you so much once again, Dr. Hasbun. Appreciate it.
Thank you, Aamir.
So for our second case, we're going to be moving on to an interesting case of azole-resistant Aspergillus in a lung transplant patient. And so I'm going to start by introducing our speaker. So we have with us today here Dr. Ostrosky, who is a world expert on fungal infections. Thank you, Dr. Ostrosky, for participating in our ICON 22 biennial conference. Dr. Ostrosky is a professor of medicine, infectious diseases, transplant infectious diseases, epidemiology, infection control, and stewardship at the Division of Infectious Diseases of the McGovern Medical School in UT Houston. He serves currently as the chief of the Division of Infectious Diseases at the McGovern Medical School. His area of expertise includes antifungal susceptibility testing, serodiagnostics, PK/PD of antifungals, in vivo models of human mycosis, clinical trials of prophylaxis and treatment of fungal infections, transplant infectious diseases, along with other studies on hospital epidemiology and stewardship. And he also serves as the vice chair of medicine for healthcare quality and the director of the Laboratory of Mycology Research. And he also serves as the director for epidemiology and stewardship at the Memorial Hermann Hospital at the Texas Medical Center. So we'll just start with our second case.
So our first case here is going to be about azole-resistant Aspergillus fumigatus. I have no financial interests or relationships to disclose. Our chief complaint for this patient was 3 weeks of shortness of breath, 3 months following a bilateral lung transplant. This was a 67-year-old Hispanic male with a past medical history of ILD, pre-transplant Aspergillus sputum colonization, for which he underwent a bilateral lung transplant in January 2021. He received basiliximab and methylpred induction. He was CMV D plus or minus high risk. received prophylaxis with isavuconazole, TMP-SMX, valganciclovir. Current immunosuppression is with tacrolimus, MMF, and prednisone. For his post-transplant course, he had certain complications early on in his course, about 2 weeks post-transplant. This was complicated by a right mainstem bronchus dehiscence and bronchopleural fistula, for which he had to undergo stent placement and subsequently an omental flap repair. This was followed by graft rejection due to acute cellular rejection A3, for which he received thymoglobulin and high-dose steroids. This was followed by an Aspergillus tracheobronchitis involving the bronchial anastomosis site and recurrent respiratory failure due to recurrent mucus plugging. Regarding his prior Aspergillus tracheobronchitis, prior to him being presented for this case, he previously had Aspergillus growing from the anastomosis site where there was dehiscence. This was a breakthrough infection on isavuconazole prophylaxis. And at the time of this case, he had just completed a 3-month course of inhaled liposomal amphotericin, isavuconazole, and micafungin for Aspergillus salvage therapy. And now he is readmitted 3 months post-transplant with worsening shortness of breath, hypotension, and hypoxemia after an outpatient bronchoscopy. He's intubated for hypoxemic respiratory failure. Repeat bronch BALs are growing Aspergillus fumigatus again. Bilateral anastomotic pseudomembranes are seen. There's bilateral bronchial stenosis requiring stents and repeat dilations. This is the CT chest. The one on the left-hand side is a pre-admission CT chest, and the one on the right-hand side is a post-admission CT chest. And we can appreciate the significant amount of disease burden from the Aspergillus in terms of nodular opacities, ground glass opacities bilaterally throughout all lung zones. Bronchoscopic findings showed on the left anastomosis, there were pseudomembranes with a lot of granulation tissue. Also on the right anastomosis, we had a lot of pseudomembranes involving the anastomosis site and a covered stent in the right middle lung. As the arrows indicate, these are where the pseudomembranes can be appreciated. The Aspergillus MICs on BAL, so we had one from before, from around March 2021. This is pre-admission, where the voriconazole MIC was 0.25, the isavuconazole MIC was 0.5, and the posaconazole MIC was 0.06. Now, at the time of during this current admission with repeat BLs, the Aspergillus fumigatus MICs have gone up. The voriconazole MIC has gone up to 1, and the isavuconazole MIC has gone up to 2. For this patient's course, he received liposomal amphotericin 5 mg/kg daily with resolution of these pseudomembranes, but had persistent growth of Aspergillus fumigatus. His course was complicated by a PA arrest following bronchoscopy requiring ECMO support and AKI requiring CRRT, along with a stenotrophomonas VAP and CMV viremia. He had severe bilateral extensive bronchial stenosis requiring repeat bronchial dilations every 48 hours. Subsequently, he underwent a goals of care discussion and was transitioned to comfort care. So we're going to have Dr. Ostrosky comment on some of these discussion points. When should azole resistance be suspected and its risk factors? Comments on the diagnosis of azole-resistant Aspergillus and the MIC interpretation for Aspergillus fumigatus. Isavuconazole MIC interpretation for this case in particular, where the MIC was 2. Comments on azole cross-resistance and treatment strategies. So handing over to Dr. Ostrosky. Thank you so much, Dr. Ostrosky.
Thank you very much, Dr. Qazi. It's a privilege to be here, joining you from Houston. We miss you here a lot, and it is really one of the most rewarding things to do is to interact with our prior trainees and see how successful you are. So again, it's a privilege to be here. I want to share my slides.
Absolutely. Thank you, Dr. Ostrosky, for joining in. For all our viewers, it's late in the night in Houston right now, and so we appreciate all our U.S. speakers joining in at this late hour. And thank you so much for participating in our ICON conference. It's great seeing you again.
Likewise. There we go. Alrighty, and can you see the slides?
Perfect. Yes.
Alrighty.
Yes, we can.
Okay, so I want to briefly go over breakthrough and refractory fungal diseases and focus on resistance, which is one of the things that we suspected in this case. And these are my declarations of disclosure. And first of all, I want to start with what the optimal response rates are for fungal infections, particularly Aspergillosis. These are the two biggest clinical trials in the area of Aspergillosis, which were the Voriconazole versus conventional amphotericin B trial, the Herbert trial, and Ambilode is kind of the benchmark trial for liposomal amphotericin B. And as you can see here, in the best of cases, these are optimal therapy, very well selected patients. We have about a 50% response rate at 12 weeks and about a 72% survival at week 12. So this is what we expect from the current antifungals that we use as the backbone of therapy for invasive aspergillosis. When we see failure, we need to suspect that there are several things that may be happening with the patient. So we divide the risk factors for breakthrough fungal infection or relapse as to host factors, fungal factors, and iatrogenic factors. And as you can see here in this consensus statement, basically the host factors are immunosuppression, intensive care unit stay, exposure to multiple antibiotics, failure of source control, different polymorphisms in sort of your genetic makeup, which we're barely starting to study. And then we move on to fungal factors, which include fungal virulence traits, including certain particularly difficult things for Aspergillus. We have antifungal resistance or tolerance, which is what's probably happening in this case. Sometimes we use antifungals that don't match the activity of the fungus we're growing. Biofilms, selection of resistance based on the antifungals that we're using. And again, sometimes we get a mixed picture of bacterial and fungal infection, and we don't know which one is responding to what. And then we have iatrogenic factors, which basically focus on inappropriate selection of antifungals, insufficient levels, protected spaces where we're not really getting any penetration, incorrect intake procedures, etc. So again, these are the risk factors for a breakthrough fungal infection. The common risk factors that I've seen over time that definitely drive the failure in our cases are primarily going to be source control. This is by far the most common thing we see in mycology, where we have an abscess, or in this case, an anastomosis that cannot be fixed, and you sort of have the fungus festering there and continuing to grow. Underlying immunosuppression. Again, our patient was severely immunosuppressed. PK issues with the antifungal you're trying to use. You're just not getting the right levels, or you're not getting to the space that you need to be getting. And finally, we need to talk about resistance. And again, in this list, resistance is down below because by far the most common sources of failure are going to be the ones that I listed in the top of the slide. And finally, we have what we call toxicity or intolerance related failure, where it would work, but the patient is just not able to tolerate the antifungal, and we just can't get enough antifungal in there to treat the patient. As far as resistance in aspergillosis, this was a phenomenon first described in Europe. We think it has something to do with agriculture, with the use of pesticides that have antifungal properties. They're similar to azoles, not quite azoles, but it is undoubtedly proven that the isolates that you find in the environment are the isolates that are eventually going to infect your patients, because we're breathing mold all the time. So again, the emergence of azole resistance was first described in Europe. It was thought to be a very local phenomenon to that area of the world, but we're starting to get more and more and more reports of azole resistance, basically in all the continents at this point in time. And again, the primary driver is going to be, like we were saying, agriculture, the use of pesticides. But the other mechanism for developing of resistance is really exposure to different antifungals and the repeated exposure to these antifungals as well. Again, this is kind of a really nice review article on azole resistance in aspergillosis. And you can see here that in general, azole resistance is low, less than 1%, but there are parts of the world in different continents that do have rates as high as 20%, 30%. And again, this is a highly localized phenomenon. The other mechanism that we were discussing is really mutations in Aspergillus. The most sort of frequent one is a TR34L98 mutation. This is what we have here in the United States, primarily here in the South, where this case was presented. And in this particular case, I don't think this was an environmental strain that was intrinsically resistant. I think this was, again, an issue of source control, where we could never get rid of the Aspergillus in this anastomosis with the sutures, and the repeated exposure to azoles eventually caused the isolate to become resistant. Now, regarding the MICs, we normally think that the breakpoint for Aspergillus is at 4, and these isolates were under 4. But when we compared the two isolates, the initial and the second one, we definitely saw a shift in MICs. And this really is telling us that this isolate is no longer wild type. It has mechanisms of resistance that have been selected with the continuous pressure with azoles. As far as treatment goes, we have different options. We have echinocandins, which have been studied in the salvage setting. I don't know if most of you know, but the first approval for an echinocandin was for resistant aspergillosis with casofungin, with a 39% response rate in refractory cases. We have the possibility of combination therapy. Ambisome and casofungin showed very good response rates in this multi-center trial. And we have the ultimate combination trial, the MSG study that compared voriconazole and adenoidal fungin with voriconazole alone. And in this study, although the primary endpoint was not met, there was a numerical difference. And in a sub-analysis where we studied patients that entered into the study based on a positive galactomannan, those patients did see a difference. So bottom line here is that using a combination of antifungals in the salvage setting is probably not the right thing to do. They have been shown to be more effective in therapy. And the classic question is, can you switch azoles? Is there cross-resistance between azoles? In general terms, we do think there is cross-resistance between azoles, but we have small anecdotal reports or case series that have examining, for example, giving posaconazole after voriconazole failure. And as you can see here in the study, there was a response in some of those patients. I don't think necessarily that this is a resistance issue or overcoming resistance, but these patients were probably not getting enough voriconazole in, and people relied on the pharmacokinetics of posaconazole to be able to get adequate levels to treat those patients. So at the end of the talk, I want to sort of leave you with really good news. We have 4 antifungals in development that are going to be addressing resistance. We have risafungin, which is a long-active echinocandin with an extremely high peak that may be able to overcome resistance in some cases. We have ibrexafungerp, which is an oral glucan synthase inhibitor that does have activity against Candida and Aspergillus. Fusmanogepix, a brand new class of antifungals that is useful for resistant Candida and Aspergillus, along with other very select molds. And olorofim, which is a really interesting drug that has activity against most molds, including the more rare ones, including some of the mucor species. So again, this is what the antifungal pipeline is looking like, and we're starting to reach final stages of clinical development, and we expect to have all these agents in the market within the next 5 years. So to conclude, there's multiple reasons or causes of breakthrough and failure, not just resistance. We have lacking data regarding refractory treatment and how to handle those patients. My advice is always to optimize the PK, choose the right formulation, make sure you're doing therapeutic drug monitoring, and there is good data for switches and combination therapy with a few new agents in the horizon. I want to finish here and say gracias, which is thank you in Spanish. We have the Hispanic influence in here in Texas, and it's really been a pleasure to share this talk with you.
Thank you so much once again, Dr. Ostrosky, for joining in and for that expert masterclass in antifungals and resistance and treatment failure. Thank you once again for joining us at this late hour at your end. And we'll be saving our questions right for the end after case 3. So we'll move along towards our next case, which is a case of gram-negative resistance with carbapenem-resistant Acinetobacter and E. coli as well. And so we'll start with the case presentation.
Good morning, everyone. Thank you for joining us. My name is Aamir Qazi. I'm an infectious disease consultant at the Indus Hospital and Health Network. We have here with us today Dr. Nigo, joining us from Houston. Thank you, Dr. Nigo, for participating in our ICON 22 conference. Dr. Nigo is an assistant professor at the UT Health McGovern Medical School. His expertise is in general infectious diseases, transplant infectious diseases, outpatient parenteral antibiotic management, and he has extensive research experience in transplant infectious complications in solid organ transplantation and big data analysis, along with machine learning. So moving on to our case. So we're going to be talking about a resistant GNR case. I have no financial interests or relationships to disclose. The chief complaint for this case was thigh wound drainage and redness after a road traffic accident. This was a 30-year-old female with a history of uncontrolled type 1 diabetes with an A1C of 14. 4 weeks prior to admission, she had a road traffic accident in a rickshaw. She fell from the rickshaw, rolled over the road and pavement, and suffered multiple superficial and deep lacerations on her right thigh. The right thigh became progressively red and swollen. She was prescribed 1 week of clindamycin without any relief. The right thigh wound deepened with purulent drainage. This is her MRI imaging of her right thigh. On the left-hand side, we have a coronal T2 image, and on the right-hand side, we have an axial T1 post-contrast image. And as the arrows indicate, we can appreciate a large collection extending down along the right thigh, involving the medial and anterior compartment with significant subcutaneous soft tissue edema and a fairly large abscess, almost 9 by 3 centimeters. These are actually post-operative wound images of the patient's thigh. Unfortunately, I did not have any preoperative images, but we can appreciate a fairly large area of involvement. And in this picture here, there's some granulation tissue formation after some slough has been debrided, but a fairly extensive wound in terms of the area that was involved. So this patient had pyomyositis, and I wanted to talk about the operative course. All in all, this patient underwent 12 debridements, was taken to the OR on 12 separate occasions. So the first time they appreciated sinus over the anterior lateral thigh, there was a 100 ml abscess that was drained. Fat necrosis was seen. There was healthy bleeding muscle, no extension to bone, and a drain was placed. Cultures from the very first operative debridement revealed ESBL E. coli, ESBL Klebsiella, ESBL Morganella, and the patient was treated with meropenem initially. The second debridement just 2 days later showed extensive yellow wound slough that was debrided and more pus was drained. Another drain was placed. These cultures grew carbapenem-resistant E. coli and ESBL Klebsiella. Therapy was modified and tigecycline was added to the meropenem for the carbapenem-resistant E. coli. The next debridement revealed extensive yellow slough and more pus that was drained. These cultures only revealed carbapenem-resistant E. coli, and therapy was continued. The next debridement revealed some necrotic slough and once again some more pus that was drained intraoperatively. Cultures continued to grow carbapenem-resistant E. coli. At this point in time, given the extensive pus that was coming out, despite repeated debridements, therapy was modified to colistin and meropenem, combination therapy essentially for the carbapenem-resistant E. coli. The next debridement revealed more pus between the vastus lateralis and IT band and separate pockets of pus between the IT band and subcutaneous tissue. Operative cultures this time grew carbapenem-resistant Acinetobacter in addition to the carbapenem-resistant E. coli. Therapy with colistin and meropenem was continued. The next debridement saw seropurulent drainage in the anterior thigh. The anterior medial muscles looked healthy at this point in time. Cultures from this operative debridement were negative. Therapy was continued with colistin and meropenem. Additional debridements saw a large amount of pus reforming in that anterior thigh. Both debridement number 7 and 8, respectively, they drained 100 cc's of pus and then 200 cc's of pus from that thigh compartment. There was additional growth of carbapenem-resistant Acinetobacter and carbapenem-resistant E. coli. Therapy was continued with colistin and meropenem. Subsequent debridements saw lesser and lesser drainage and healthier looking tissue with eventual formation of granulation tissue. And eventually they were not finding any more pus. Subsequent operative cultures were negative, and the patient finished a course of colistin and meropenem. This is the sensitivity profile of both the carbapenem-resistant E. coli and the Acinetobacter. I'll pause here for a second. And this will be the main discussion point with Dr. Nigo for today. Colistin MICs were run for both the E. coli and Acinetobacter. It was 0.12 for the E. coli and 0.5 for the Acinetobacter, essentially interpreted as not resistant and thought to be within the paradigm of sensitive. For this patient's course, they completed 5 weeks of colistin, colistimethate essentially, and finished 3 weeks of colistin after culture clearance. Combination therapy, along with prolonged infusion meropenem, was continued throughout this course. The patient had clearance of intraoperative cultures, and eventual wound closure and healing was achieved with repeated INDs and antibiotics. The limitations in our setting are that the therapeutic options for CRE and CR Acinetobacter are limited to tigecycline and colistin at our institute and typically in Pakistan. Molecular diagnostics are not available. Colistin MIC is performed via broth microdilution. MICs for other gram-negatives is performed via VITEC. So Dr. Nigo, for our discussion points, we'd like your comments on the types of carbapenemases, identification of carbapenemases, treatment strategies in the US for carbapenem-resistant E. coli, and carbapenem-resistant Acinetobacter. Your thoughts on treatment strategies in a resource-limited setting like ours, and your comments on Choristine combination therapy versus monotherapy. Thank you, Dr. Nigo. Handing over to you.
Can you hear me?
Yes. Hi, Dr.
Okay.
Nigo. Thank you
Hi.
so much for joining in.
Okay, great. Thank you for Dr. Qazi and the organizer inviting me for today's presentation. I'm honored to be here. So let me share my screen. Can you see my screen now?
Perfect. Yes.
Okay, great. So I don't have any financial interest or relationship to disclose for this presentation. So I was asked to present, the carbapenem resistance E. coli and Acinetobacter, such a big topic, in 10-15 minutes. So I will try to squeeze in a lot of things into my presentation. So the first, the type of the carbapenemase. So there are two different classifications usually used for the beta-lactamase. So one is the Umbra classification, and the other one is the Bush-Jacobi classification. So in general, Umbra classification is more useful for the clinical use. So we often remember these classifications when we select the newer agent for the carbapenem resistance bacteria. So originally, Umbra classification started with the class A and then class B based on active site of the irons. The one is a serine, and then the other one is a zinc. And then later, this class A was divided further, getting into a class C and then class D. So that's why we have a 4 different classifications, classes. So class A, the main example of the beta-lactamase or carbapenemase is the CTXM that confers the ESBL resistance to the isolates, and then KPC is the carbapenemase. Then this class A is more common in Enterobacterales, and then such as E. coli or Klebsiella, and then this is one of the most commonly seen in the United States. And then class B, as known as the metallo-beta-lactamase, and then contains NMD1 and IPM and then BIM. This is also seen in Enterobacterales. And then of note, this metallo-beta-lactamase, aceronam remains stable, so it can be one of the treatment options with combining with other medications. We'll touch on that in a later slide. And then a class C, the main example is the beta-lactamase. Main example of the beta-lactamase is AMP-C. This is often seen in Enterobacter or Strobacter. And then finally, the class D contains the OXA. And then one of the example of the carbapenemase is the OXA48, which is mainly seen in Acinetobacter. But OXA-A is sometimes seen in the Enterobacterales, and then at that point, and in that situations, the treatment option is slightly different, carbapenem resistance Acinetobacter. So we will show you in the other slide. And then the important thing is, we are focusing on a carbapenemase, but however, those drug resistance bacteria could have a different mechanism of the carbapenem resistance, such as a pollen or efflux pump. So especially when you're looking at like Pseudomonas or others, you have to be careful. Not only the carbapenemase can confer the carbapenem resistance, and then in order to increase the sensitivity to detect the carbapenemase, the CLSI recently decreased the breakpoint of the carbapenems, such as the ertapenem breakpoint came down from 2.0 to 0.5 to increase the sensitivity. So in order to identify the carbapenemase in a clinical lab, we have a couple options in the United States. So the conventional method is using a microplate, and then such as modified Hodge test or modified carbapenem inactivated method. The cons of this procedure or method is you need to do the incubations. And then also sometimes, when we interpret, it could cause a false positive or false negative depending on operator. And then the other method is a biochemical test or immunoassay. And some of them are called like a CARBA-NP or CARBA-5. And that's a more rapid test. And then you could do the any isolate from any samples. And then they can identify some of the carbapenems we just talked about. Then a more advanced method, such as molecular method, the multiplex PCR from the blood culture. And for example, the BioFire or Virgins are commonly used in the United States, US hospitals. And then a good thing is, once it become positive, the blood culture, you don't need to do a subculture to get the actual isolate. You can use actual blood cultures, positive blood culture, to identify those pathogens, as well as the resistance mechanisms, as we just talked. And then also there is another option, is the multiplex PCR from the respiratory sample. And one of the vendor, BioFire, has a pneumonia panel, which include some resistance panel as well, in addition to identifying a bacteria. And then lastly, the RT-PCR, and you can do it from the isolate from any sample, but you have to have a special instrument to do it. So those are the main method to identify the carbapenems in the United States. Then a treatment strategy in the United States for carbapenem resistance, E. coli or Enterobacteriaris, or carbapenem resistance. I created a table because it's going to be a more complicated and then also the confusing. So in this table, as you can see on the left-hand side, those are the newer antibiotics available in the United States. The first one is Ceftolozane Tazobactam, and then this antibiotics is mainly used for the MDR Pseudomonas, and then ceftazidime avibactam, meropenem, valbobactam, imipenem, lerobactam. Those are the new combined medications with the newer beta-lactamase inhibitors. And then those newer beta-lactamase inhibitor has a different property to break down those carbapenems. So as you can see here, the avibactam can break down the ESBL, KPC, as well as OXER. And then the valbobactam or lerobactam is mainly for the KPC isolates. And then lerobactam, sometimes we can use MDR Pseudomonas as well. And then the cefiderocol is a newer antibiotics, which is approved almost a year ago. And then that has the really good in vitro activity against all those pathogens. And then the plasmycin is a newer aminoglycoside, which also has good activity against carbapenem resistance. And then eravacycline is a newer glycylcycline that in a similar group of the tigecycline has remained some activity as well. And then finally, the fosfomycin. The interesting thing is understanding those carbapenem resistance mechanism, and then you may be able to find the potential treatment options. And then obviously, even though they have some activity in vitro, if you do the actual phenotypic testing, it sometimes came back resistance. So you also have to wait for the phenotypic testing results. But at least based on the rapid testing, rapid detection of the carbapenems, you may kind of guess which treatment may be more effective compared to the other. And I wanted to also touch on some treatment strategy for the carbapenem resistance Acinetobacter. And then, as you know, the conventional agents, we have a couple options as long as it's susceptible. One is aminocycline. We usually use 100 milligram BID, but for the Acinetobacter cases, we can increase to 200 BID. And then tigecycline also can be try higher regimen as long as patient tolerate the GI tolerance. And then ampicillin Pseudobacterium is revisited as a good option for the treatment for the carbapenem resistance Acinetobacter. But in these situations, you have to use really high dose, like 9 gram Q8 or 27 milligram a gram over 24 hours. And then Choristine and polymyxin is another option as used in this case. And then a newer agent we just touched on, cefiderocol, and then eravacycline. Those are potential options. And then it's coming soon, but a newer agent, Sulbactam and Durobactam, because the Acinetobacter is susceptible to Sulbactam, that's a beta-lactamase inhibitors, and they added additional beta-lactamase inhibitor to enhance the activity of the antibiotics, and then potential future therapeutics. And then there is a case report, and they use the phage therapy to treat those patients. So I just wanted to touch on one newer antibiotics most likely will be available in near future in the United States, is the Sulbactam and Durobactam. So this study is only published in the press so far, but the phase 3 trial, ATTACK trial, they have two groups, and then one is the Sulbactam and Durobactam versus Choristine for the Acinetobacter, carbapenem-resistant Acinetobacter, hospital-acquired bacterial pneumonia versus BAT. And then a
Dr.
part
Nigo,
B.
I hate to rush you. Just a
Yes.
couple minutes remaining.
Oh, okay, sure. And then open label studies, and then after the fading of Choristine and polymyxin, and then basically they found the mortality was 19% versus 32%. And then the part B also similar mortality rate, 17.9%. Then I also would like to touch on Choristine combination versus monotherapy. So when we talk about this, and then we should understand the pharmacokinetics of the Choristine and polymyxin B. So as you can show in the left-hand side, this is the Choristine. After they administer the Choristine inside the system, it needs to be metabolized by the kidney and then to be active medication. So the issue is depending on the patient, they have like a wide range of the conversion rate to active metabolite. But on the other hand, the polymyxin B, if they are giving like actual active medications, so there is a smaller variance based on the patient. So the systemic Choristine dosing in our hospital is, as I just said, it has like a variability of the drug concentration. So we often give like loading dose, 5 mg per kg, and then adjust the dosage as well based on the kidney function. And then we often use this is still controversial, but we often use other agent such as meropenem, like this case, or tigecycline. And then a polymyxin B dosing in our hospital is, the 500,000 polymyxin is usually 15,000 to 25,000 unit per loading dose. And then the good things for the polymyxin B, you don't need to adjust based on the kidney function. Then we often use as a combination. So the treatment, but the issue is, for example, polymyxin B is not available in Pakistan or some other countries. Fortunately, in the United States, we have both options. But if the treatment, we have a limited setting, for example, like those newer agents came out to our market, like, about 5 to 10 years ago. But before that, we didn't have the option as well. So the other important thing is optimizing, the pharmacokinetics of the existing antibiotics. So for example, as I said, the carbapenem breakpoint has been decreased. So knowing the actual MIC of those antibiotics is really helpful to decide which antibiotics may be useful. So for example, like this is one of the pharmacokinetic study with a Monte Carlo stimulations. As you can see, the meropenem 2,000 gram Q8 over 3 hours maybe overcome some of the higher MIC currently considered as the intermediate or resistance. So the adjusting the pharmacokinetics is really important. And then lastly, I would like to touch on ampicillin and Sulbactam. So the Sulbactam has an activity against Acinetobacter species. So the newest guideline just published in December recommend a high dose of the ampicillin Sulbactam, either 9 gram IVQ8 or 27 gram Q24 hours. If it is a mild case, you could consider a little bit lower dose. And but they usually recommend with a combination of the other agents such as polymyxin or others, if the case is a really severe case. And then also we still don't know appropriate MIC cutoff of the ampicillin Sulbactam against these isolates. So the future study needs to be done to find optimal cutoff for those. So take home point. So understanding a mechanism of the resistance helps select the newer antibiotic therapeutic option for the carbapenem resistance organisms. Rapid diagnostics improve the antibiotics optimization in timely fashion. And then PK/PD of the antibiotics is important to optimize the therapy, especially for drug resistance organisms. And then I didn't touch on during this presentation, but as this case, the source control should be optimized to effectively treat those complex patients. Okay, and thank you for your attention. And I'm happy to take any questions.
Thank you so much, Dr. Nigo. Appreciate that detailed talk. It was a very broad topic that we asked you to present on, but thank you for squeezing that in. Appreciate it. So we're going to move on to our Q&A session as well. And so if there are any questions for Dr. Nigo, that would be great. Or we do have some questions in the panel as well. And if we could have Dr. Sumaya and Dr. Azizullah Khandilo just make some comments on these questions. Any specific questions for Dr. Nigo while we still have him here? All right, we'll get started with question 1 from Dr. Wahid Hussain. And this is regarding CMV and its treatment. And the question is regarding what would be the preferred antiviral indicated in the early phases of BMT engrafting. Keeping in mind that post-BMT, we have issues with cytopenia, graft failure, and so what is the optimal CMV strategy for post-BMT as far as CMV prophylaxis is concerned? Oh, I think Dr. Hasbun, I think you're muted.
Okay, can you hear me now? Perfect. Yeah, so that's an excellent question because with after engraftment, you got to be worried about anemia, neutropenia. So now we have letermovir, and letermovir does not give you anemia and neutropenia, and it's indicated for bone marrow transplant. So, you know, there's been a shift now to using more letermovir than valganciclovir in this setting.
Perfect. Thank you, Dr. Hasbun. I think our other 2 questions also pertain to CMV. Okay. So question number 2 is from Dr. Sunil. What would you suggest for a kidney transplant recipient that is D+, R+, so intermediate risk, a living related donor, and a very good match receiving no induction therapy and is on azathioprine and cyclosporin and prednisone maintenance? Is the best, what's the optimal approach in this setting? Universal versus preemptive CMV therapy versus hybrid?
Sure. So this would be an intermediate case. So you could make a point for preemptive therapy in this scenario and just monitor the CMV PCRs for this patient. If the patient's high risk, valganciclovir would definitely be more appropriate for prophylaxis here.
Perfect. And our third question is from Dr. Said Faisal Mahmood. In the absence of newer antivirals and genotyping in Pakistan, any advice on how to deal with a refractory case of CMV in Pakistan?
So if there's an absence of genotype in Pakistan, then if you have refractory CMV infection with an increased log after using valganciclovir, I think it's safe to assume after you switch into ganciclovir IV for any possible malabsorption, and if they still continue to have viremia on IV ganciclovir, I think you have to presume the possibility of ganciclovir resistance, and at that time you would switch to either a foscarnet, and I don't, marivir obviously would be another option in the future as well.
Dr. Hasbun, your comments on so foscarnet is hard to come by in Pakistan. I think in select cases one may have to get it from abroad. Your comments on in a case where foscarnet may be lacking, maybe in terms of doing higher dose ganciclovir or reduction in immunosuppression.
Yes, so always that's definitely an option to stop the mycophenolate or decrease the other immunosuppressants as well. But higher doses, I think if you've already done induction doses with the standard doses of 900 BID, the thing to do would be to switch to IV ganciclovir because there could be some issues with malabsorption in that setting.
Perfect. Thank you so much, Dr. Ostrosky, Dr. Hasbun, Dr. Nigo. Thank you for participating. We have another question from Dr. Naseem Salahuddin. In the absence of newer antibiotics, is IV fosfomycin in combination with colistin useful against Acinetobacter? Dr. Nigo, your comments.
Yes. So unfortunately, the IV fosfomycin is not available in the United States. If it is a CRE, like Enterobacterialis, it may be a possible option. But Acinetobacter, the fosfomycin may not have a good activity against it. So most likely, I would choose the other options.
All right. I think in just the interest of time, we'll have to pause here with additional questions. And thank you so much for all our speakers and to our participants. Thank you. Take care.
Thank you very much, man.
Thank you.
Thank you.
A very informative discussion indeed. And this is how you get to learn ID. So let's continue the aura of IDs and move on to our next discussion, that is by Dr. Juzar Ali. He is a professor of medicine at LSU, is an academic clinician. He's a clinical educator and researcher in the section of pulmonary critical care at LSU Health Sciences Center, New Orleans. And he has also worked in health and hospital administration throughout his tenure, with practice experience in Pakistan, India, Kenya, United States, and Turkey. He has participated in various multi-center studies and trials of tuberculosis and non-tuberculosis mycobacteria, and has also co-authored a textbook. Today, he'll be talking about the non-tuberculous mycobacterial pulmonary diseases, the past, present, and future insights. Over to you, Dr. Juzar.
A colleague of mine and a friend for allowing me to share this presentation with the August group over there. My topic today, as you know, is going to be non-tuberculous mycobacterial pulmonary disease in a non-HIV setting. And I will share with you my past, present, and future insights on this. My background, as you can see, is coming out right now from the LSU School of Medicine. They used to be called anonymous pulmonary mycobacterial disease, atypical mycobacteria, and so on. And I'm sure you are aware of these names. One of the names that was used before NTM was called MOTT, M-O-T-T, mycobacteria other than TB. NTM has a close link with tuberculosis, as you all know. And we've always talked about this thing, when we have joked around in our clinical setting, is it TB or not to be, TB or not to be, taking it from our ham. You have a risk of TB, you have the signs and the symptoms of TB. You may or may not do the immunological tests, such as the skin test or the IGRA test. That is not necessarily all the time needed. Of course, you have a smear of acid-fast bacteria. If you have the setting, which I think are very easily available everywhere now, you do the PCR or the nucleic acid amplification test. You plant it for culture. If there are probes available, you probe it for TB, and then you have the final culture or the tissue diagnosis. Along with that, you have the X-ray picture, which you can see over here, typical of upper lobe fibrocavitary disease, also seen on the CT scan. So at this point, it's pretty straightforward. It's TB, looks like a duck, walks like a duck, must be a duck. But sometimes it's not. And when it's not, it's what I call the TB wannabes. They look like TB, they want to behave like TB, but they are not. The basic pathology in mycobacterial disease, as you very well know, is essentially a journey from macrophage to inflammation to granuloma formation. And I'll be discussing a little bit more about the granuloma formation because it is assumed that a granuloma is a rounded, spherical, uniform, homogeneous entity, whereas multiple studies done, and as recent as a recent study that has come out in 2021 discusses the heterogeneity that you see with non-tuberculous with a granuloma, whether it is TB or whether it is a non-TB granuloma. A granuloma necessarily does not mean a spherical, round, homogeneous entity. It can be heterogeneous. It can be originating in the lung in the form of a nodule. It can be originating from the airway and then extending the inflammation to a granuloma formation and then cavitating or getting necrotic and so on. So the point being that it's a heterogeneous phenomena. And so when you see a calcified granuloma on a chest X-ray, we clinicians generally would assume that it's a straightforward thing, rounded thing, etc., but it's actually not. When we talk about the classification of mycobacterial disease, and I don't mean to insult your intelligence here, but it's essentially important to recap that on one hand you have TB, and on the other hand you have the slow-growing mycobacteria, which are divided based on their previous Runyon group classification, which originated from the Runyon classification of 1959, if I'm not wrong, where the photochromogens were called the Kansasii, the scotochromogens were the ones that had the Gordoni and the scrofulum, and then the non-chromogens, the group 3, had all the avium intracellulare, and then you had the second, the last group, which was the rapid growing mycobacteria. Moving along, as far as pulmonary disease risk factors are concerned, if you look at the two columns over here, on one side, the non-tuberculous mycobacteria risk factors, and what are the risk factors for TB, what I've highlighted is the commonality between the two. So the risk factors essentially are not very different. You have on the TB risk factors, the patients with HIV, with transplants, with silicosis, with immune deficiencies, carcinomas, patients using TNF blockers, glucocorticoids treatment, cigarette smoking, and so on. And on the other hand, you have the non-tuberculous mycobacteria risk factors, which include almost the same thing with the addition of or supplementation of other diseases, such as emphasis on GERD, immune deficiencies, patients living with HIV, of course, and then, of course, the exposure history with soil exposure and so on. So that begs the question, non-tuberculous mycobacteria, is it real or is it just our quirk of finding or trying to find something with it or about it? And the answer is that more and more data now suggest, epidemiological data, public health data, etc., that it's a real phenomena. And this particular slide shows you that the distribution of NTM, especially MAC, which is this color over here, is pretty much ubiquitous, and it is all across the globe. You can see it in Europe, North America, South America, Asia, and all across. The next two slides are not supposed to be read by you because you won't be able to read it. It's a very busy slide, but what I want to show you, the purpose of that, these two next slides are that it's there. It's been mentioned in the literature, and these are the quotations of the literature in Iran, India, Saudi Arabia, Egypt, and South Asia and the Middle East. And then, of course, nothing can be further from the truth, but we have publications from Pakistan, and especially from certain centers in Lahore and in Aga Khan University. And these are the examples of publication of NTM that are being seen and prevalent in our part of the globe over there in Pakistan. So now let's move on to my theme over here with that introduction, that yes, it's there, yet yes, it is different from TB in some aspects, yet it is same like TB in some aspects. But then let's move on to the theme of what it was, the perspective in the past, and what it is now, and what will it be in the future. As far as the past is concerned, the journey is actually from through the epidemiological and clinical cohort. And what I'm showing you three over here are the three landmarks of this journey. The first one is when disseminated MAC was detected in HIV in the 80s, and it became a part of the disease process. Just as HIV and TB became a double jeopardy, so was disseminated MAC. At that time, disseminated MAC, or non-tuberculous mycobacteria, was of an intensity that was not limited to pulmonary disease, but had GI symptoms as well as intra-abdominal symptoms and hematological manifestations. So that was the first quote-unquote experience with NTM in a very important public health as well as clinical syndrome of HIV. Around the same time, in the early 90s, there was a description, and the publication is mentioned on this thing, where a certain phenotype of a patient was described. This phenotype was a middle-aged, elderly, white lady, and she was complaining of chronic cough, repeated bouts of bronchitis, etc., and had a phenotype presentation: thin, frail, very energetic in one way, but at the same time very conscious of her cough. And Oscar Wilde's play was invoked in this, and this particular syndrome of a patient was called the Lady Windermere syndrome, based on that Oscar Wilde's play. That was the second cohort. And then the third cohort of NTM disease was in the multi-center prevalence studies that was seen with cystic fibrosis. So the past of history of NTM can be seen from these particular cohorts that I have been talking about. Now let's move to the present. Where are we with NTM disease, pulmonary disease, and especially I'm talking about in non-HIV, where are we in the present? To appreciate the present, I will share with you my perspective. And this is a perspective that I have been following in my own clinical arena and my clinical research arena. And the perspective is twofold. I've published this in this review article in 2021. The first perspective is that when you talk about NTM pulmonary disease, you should think of it like it is the tip of the iceberg. The tip is the infection, the non-tuberculous mycobacteria. And of course, it's complexities. The lower level below the tip, which is very important, is the underlying primary or secondary bronchiectasis that occurs in this condition. Very important in my mind to appreciate that. The middle level is the pulmonary comorbidities that occur with bronchiectasis, and we'll talk about that. And the lowest level of this iceberg are the other contributing factors or associations that occur with this disease process. So that's one perspective. Keep that in mind if you can. The second perspective is that when we are handling or managing non-tuberculous mycobacterial disease, pulmonary disease, we need to keep in mind that it's not a simple thing of writing the antibiotics. It is, in fact, a multidisciplinary approach. And what I have designed is I have designed an alphabet pathway from A to I. I stopped at I because the next one was J, and J is my name starting. So I said, let me better stop there. But from A to I, A, awareness of the disease, B, the underlying bronchiectasis, C, the underlying comorbidities, D, the actual disease of NTM and its complexities, E, the environmental issues related to this, F, the follow-up, G, the impact of gastrointestinal reflux and its various precautions that are needed in this disease, H being a holistic approach that is needed in this disease, and I, the immune and the genetic testing and the immune deficiency syndromes that need to be checked when we are dealing with this. That perspective of A to I is what I'll be sharing with you as I move on. So let's start with A. A has been actually a 5-step awareness. The 5-step awareness that has happened over the years, and especially I would say over the last 20 years or so, approximately speaking, has been the transition from the concept of NTM being just a colonizer to the understanding that it could be an infection, to the realization that it could be a disease process, to the stark realization that it is associated with comorbidities and hence not necessarily independent phenomena. And last but not least, the real awareness that you can have increased mortality with this disease. So how big is this problem? Well, based on the prevalence of the disease, based on various tests, whether you talk about skin test, whether you talk about lab specimens, etc., the disease prevalence is rising all across the globe. There's no doubt about it. Also, 40% or more are associated with comorbidities where there's likely to be increased mortality. So therefore, there is increased mortality. And the fact that previously we used to say that most people live with it and die with it is incorrect now. There are 30 to 40% of the patients that may die from it. And that's the awareness. The next awareness issue is, or focus has to be the clinical recognition and having a high index of suspicion. And especially in those areas where maybe TB is not that prevalent or incidence, like on the Western hemispheres, or even in those areas where TB is very high and everybody thinks of TB first, and rightly so, they should always rule out tuberculosis. But once they have ruled out tuberculosis, or they are looking at a difficult to treat TB, or they are thinking of quote unquote MDR TB, etc., and things are not going in the right direction, then a high index of suspicion for NTM needs to be entertained. Clinically speaking, recurrent bronchitis, recurrent infection, cough, associated bronchiectasis, whether it is a primary, secondary, or an idiopathic bronchiectasis, associated comorbidities, associated HIV or cystic fibrosis, which may be checked. And then the exogenous and the endogenous immune deficiency syndromes, either related to chronic steroid use or other immune deficiencies. These are the factors that prompt you to be highly aware of the NTM disease. Then we come to B, the underlying bronchiectasis, the second level of the iceberg, as I mentioned. Now, this can be primary bronchiectasis. This could be secondary to infection, of which you all are very familiar with. And fortunately or unfortunately, it can be so-called idiopathic. And in that case, it is not clear what starts it. Is it inflammation to infection or infection to inflammation? So we go through this chicken and the egg dilemma. To recap bronchiectasis from the perspective of pulmonary disease, once again, keep that in mind, that it is where there is ectasia of the peripheral airways with cystic dilatation, and then inflammation cascade leading to granuloma formation, leading to cavitation or destruction. And once again, let me remind you about the reference that I made regarding the heterogeneity of the morphology that you see in a granuloma. So a granuloma may not be necessarily intrapulmonary alone, but it could be an inter-airway granuloma. It is important to understand that what prevents or what is the focus of treatment for bronchiectasis is the fact that you have got to have a defense phenomena. And this is just a recap of the defense that we have as far as the upper airway and the lower airway respiratory tract that keeps our airway clear and acts as an airway vacuum. And that airway vacuum will, with ciliary motility, etc., if that is hampered due to inflammation, infection, or immune deficiencies, will obviously precipitate or exaggerate the bronchiectasis. So infection to insult in the impaired host, that is the triad of bronchiectasis. And as I keep repeating, I lay a lot of stress on bronchiectasis when I'm dealing with NTM. And this is just a quick summary of that, where there are host response issues that cause contribute to bronchiectasis. And even in non-CF patients, there may be anatomically inflammation, edema, ulceration, neovascularization, etc., with increased mucus production and causing and precipitating bronchiectasis. So if bronchiectasis is the key for the management of NTM pulmonary disease, then it behooves us to focus on that. And for those of you who are familiar with the pulmonary management of that, it is a global management that ranges from airway clearance techniques to appropriate antibiotic use when we need it, to anti-inflammatory medicines, etc., if we need it, to surgery, to checking for immunoglobulin deficiencies, and then if it is severe, to go towards resection or even lung transplant. And when we think of bronchiectasis, keep in mind once again that same issue, that it is very closely related to granuloma formation. So it may be very mild, where the X-ray may be totally negative. You know very well that X-ray, chest X-ray, does not necessarily pick up mild bronchiectasis. A CT scan may show some peripheral nodules like this, may show some cystic changes and some tree in bud changes. So the tree in bud changes, the nodular changes, the ground glass changes, this is all part of the radiographic variability of bronchiectasis that is a hallmark of NTM pulmonary disease. And once again, this is in consonance with the concept of the heterogeneous multidimensional morphology of inflammation and granuloma formation. Now keep that in mind and then look at NTM pulmonary disease. And here I've shown you some x-rays. All of these x-rays are from my patients, where we have tree and bud formation, cystic bronchiectasis, cavitary bronchiectasis, cavitary disease, and almost radiographically looking like tuberculosis, and then in rare cases, pleuropulmonary disease. And the progression of this bronchiectasis to fibrocavitary disease with lung destruction, as you can see in some of these slides and here, is what leads to respiratory insufficiency, respiratory failure, hypoxemia, cor pulmonale, and finally may lead to death. As far as the C alphabet is concerned, we talk about comorbidities, and the comorbidities in pulmonary disease are essentially either related to where it is NTM associated with TB. About 3 to 10% of the patients will have some growth of NTM while we are treating them for TB. Now, whether we decide to treat NTM or we just watch it is a different issue, and that's a clinical decision based on how you believe whether this is a one-time deal or colonization, so-called, or infection or disease. That's a separate discussion. But in cultures, as we are culturing patients for the follow-up of TB, we will find growth of NTM where the AFB may be positive, but the culture for MTB is negative. And if it was cultured for NTM, it might have grown chelonia, or it might have grown abscessus, or it may have grown MAC. Of course, old TB cavities, COPD with its bullous disease, sarcoidosis with its fibrocystic disease, IPF with its pulmonary fibrosis, connective tissue disorders with its interstitial lung disease, all of these are pulmonary comorbidities that are associated with NTM pulmonary disease. Now we come to D, the disease itself, the core of it for this August group, which I'm sure is very well focused on, very well knowledgeable about the disease itself as far as the treatment and so on. So let's talk about the disease itself. When we talk about the disease itself and speaking, putting your off or with, it has mycobacterial evasion, inefficient treatment options. The intracellular barrier that occurs prevents the macrophage ingestion. The hydrophobic nature of NTM with drugs, it makes it very difficult for antibiotics to permeate. Example being rifabutin better than rifampin, although not very well tolerated. Then you have barriers of permeability. You have caseation. You have mucus growth, especially in case of Mycobacterium abscessus, and a biofilm growth. With all that in mind, these are the hurdles that one faces to eradicate the infection. And that is where, ladies and gentlemen, this is a different disease of management and treatment than TB. I sometimes joke that give me 20 patients of MDR TB and I think I can handle them. Give me one patient of difficult MAC with complexities and it's really a difficult problem to deal with. Then we move on to E, the role of environment. My clinic is called Environmental Lung Disease NTM Bronchiectasis Clinic, and I chose that word long time ago. I was made fun of, but I think I am right that it is an environmental problem, and NTM disease is exposure is aerosolization and inhalation. It can be gastric swallowing and aspiration or micro aspiration. It can be from skin and injury and surgical diseases, and it can be spread from certain cattle, etc. It can be seen in coastal swamps, garden and potting soils. It can be seen from water outlets and refrigerators and water tanks, from shower heads, humidifiers, and so on. So once again, colleagues, environmental considerations, much as they are so non-specific in most parts of the clinical arena, sorry, it is important to keep that in mind as one of the precipitating or contributing issues. These are some of the specific studies where proven routes of NTM have been noted: drinking water, showerhead, household plumbing, and so on. Then we come to F, the follow-up challenges. Once you diagnose this patient according to the criteria that you are very familiar with, the guideline criteria of persistent, consistent growth, and so on, the triad of clinical, microbiological, and radiological presentations dictate you to diagnose the patient with NTM pulmonary disease. Once you do that, the follow-up is critical. Sometimes the follow-up cultures are important, but you need to keep in mind that there can be some underlying disease. The response and the adherence to treatment is very erratic. And since the resolution of the symptoms are also very different for different patients, the compliance and the adherence to therapy is very different. There are very much high dropout rates. We generally don't do DOT with NTM disease. And most importantly, certain data has come out of the public health epidemiological studies in Oregon, where about 50% of the patients, once started for NTM treatment, either reduce their treatment, drop out of the treatment, or get their treatment modified after about 6 months. We move on to G, and that is the importance of reflux, gastric aspiration, understanding of microaspiration, which can contribute to the growth of non-tuberculous mycobacteria in the bases of the lung and with swallowing defects, and this is especially seen with rapid growers such as abscessus and Gordoni. H is the holistic approach that must be understood. Keep in mind that especially in this part of the world, and I'm sure most of part of the world, the age group of NTM pulmonary disease and the underlying risk factors and the association of other conditions with it is different than the young person, the 20 to 40-year-old who has TB. For tuberculosis, the symptom response is pretty good. The treatment seems to be working and everybody is happy. In case of this, there is a chronic issue about cough, weight loss, fatigue are debilitating complaints. This is a chronic disease. There's a lot of focus needed on psychosocial issues, on nutrition, on general well-being, because you don't have a happy patient all the time. And an unhappy patient is generally a non-compliant patient. Then we move on to the last alphabet, and that is I, where immune deficiencies, checking for cystic fibrosis, alpha-1 antitrypsin deficiencies, immunoglobulin deficiencies, connective tissue disorders, associated ANA disease processes such as scleroderma, or exogenous immune deficiencies where we give patients TNF blockers, or we give them steroids, association with rheumatoid arthritis. All of these are important considerations when we're dealing with NTM pulmonary disease. So where does that all summarize into? It summarizes into the fact that it is an oncology paradigm. When we deal with NTM pulmonary disease, it is a multidisciplinary approach. it is almost like I keep telling my medical students and my residents and my colleagues even that NTM pulmonary disease today is where oncology was 20 years ago. We have very few things to deal with, and we are really are now looking at a paradigm where we have to have a very much of a multidisciplinary approach. It is a chronic disease. So antimicrobial therapy is just one of them. The underlying disease is the second. The laboratory assessment of its speciation and colony count is important. Nutritional and watching weight loss is critical. The partnership with respiratory therapy for airway clearance techniques for bronchiectasis is crucial. And then the psychosocial support. And now we move to the future. What is it in the future? In the future, we need better rapid diagnosis, better speciation, broader susceptibilities, and a better in vivo and an in vitro match. Which brings me to what I would like to share with you. And again, a busy slide, but the purpose is an introduction. And that is that we are now at our center in my lab over here doing some preliminary work on seeing whether, other than cultures and genetic testing, can proteomics play a part in assessing the subspeciation of NTM. And our hypothesis is that all of these NTMs, the rapid growers and the non-rapid growers, etc., have a unique protein footprint, and this proteomic footprint may help us to speciate that rather quickly, rather than waiting them for a few weeks that we have to do now. The common clinical challenges related to the treatment of antimicrobial therapy is there, which is again the kind of the future questions. Who to treat, how long to treat, what are the outcome parameters, what do we do with the fact that we are dealing with drug intolerance, drug side effects, drug-drug interactions, the lengthy, complicated regimen, and then the susceptibility data and the discussion and the debate all the time between the MICs and the AUCs, area under the curve, etc., and the complexities thereof. It's not a very clear-cut, clean, resistant in vitro and in vivo resistance match. So these are the clinical trials going forward. The treatment options that we have are the increased use of ALIS, which is the amikacin liposomal inhaled solution. Focus on some inhaled therapy would be a very interesting way to go, especially when we talk about the granuloma and its heterogeneity. Clofazimine is back in the limelight. In MDR NTM, especially MDR abscessus and MDR MAC, discussion about the use of bedaquiline. And then finally, the use of combination drugs and the bronchiectasis clinical trial with the brensocatib clinical trial that I just talked about. Challenges going forward in the future continue to remain the adherence to therapy, the better treatment options that are user-friendly, the discussion between the resistance and sensitivity debate and the so-called AUC-MIC ratio. The biggest problem with rapid growers and the emergent problem with Mycobacterium abscessus. And lastly, developing better multidisciplinary platforms, because if at all you take something out of this, my presentation, very respectfully, I would like you to take this theme back, that it is a multidisciplinary platform that is needed for NTM management. It is not just simple one way where you treat only one particular aspect of it, whether it is bronchiectasis, whether it is antibiotic therapy, whether it is related to comorbidities and so on. It is a multidisciplinary approach that is very much lacking even in the most advanced countries, even lacking in my center, unfortunately. So it is not something that is easily obtained. It is very well said, but that is what is needed to manage this chronic debilitating disease that is for which we don't have too much of a positive result and a cure. With that, I thank you for your kind attention. I hope this has been helpful. And if at the time when we are presenting this, there are any questions, I'm open to it. My contacts are available with the organizers and with Dr. Naseem Salahuddin. Thank you very much. Shukr. Alhamdulillah.
Thank you, Dr. Juzar Ali. It was a very interesting talk, and I've been learning quite a lot from this session. And I hope that everybody else is also enjoying and they are also learning. So, continuing the process of learning, we have our last talk of today by Dr. Naseem Salahuddin. She is my mentor and the professor and head of Department of Infectious Diseases in the Indus Hospital and Health Network, Director TB Clinic in the Indus Hospital and Health Network, and CPSP Supervisor of ID Fellowship. She has been the whistleblower and activist for rabies in Pakistan and is a member of WHO Experts Advisory Panel on rabies since 2004. And that is what she'll be talking about today, the question, can Pakistan eliminate rabies by 2030? Over to you, Dr. Naseem.
Thank you, Rabia, for this nice introduction. And good morning, Assalamu alaikum to everyone. Can we, yeah. Where's my slide? Maybe the first one. Yeah. So can you hear me? Rabia, you okay?
Yes, Dr. Naseem, we can hear you and your slides are also visible.
All right, thank you very much. So rabies is probably the most neglected tropical disease in the world in amongst the low and middle income countries. And in Pakistan, despite thousands of deaths every year, this still remains an orphan disease. So I chose this topic more as a rhetoric rather than an affirmation of whether we can eliminate rabies. No. How do you want that? You need to press this. Okay, thank you very much. Yeah. So tens of thousands of people living in the low and middle income countries here in Southeast Asia and Africa and Central America, more than 80% of these people are exposed to rabies and live in poor conditions, and this is why there is a lot of rabies. The fact is that the rabies virus lives in the saliva of infected animals, and mostly it is stray dogs. And once the virus enters the body and moves on to the brain and symptoms appear, it is 100% fatal. And about 40% of the victims are children below the age of 15. And yet you can prevent it easily if you do the right kind of a management. So why is rabies so neglected? Number one, there is a low awareness amongst the healthcare workers and general public. They just don't understand what happens after a dog bite, and they apply all kinds of home remedies. There is inadequate data. There's lack of multi-sectoral collaboration. There's unsettled national politics and policies, as well as misplaced priorities. Oh, the slide gets stuck. How do I move this? Okay, I know this is a very offensive slide, but it really reflects the poor governance in most of our cities and small towns. We're just riddled with animals, stray animals. Over here at the Indus Hospital since 2009, we have treated more than 50,000 animal bite victims by giving them the correct PEP, PEP, post-exposure prophylaxis, and nearly half of them are category 2 or category 3 wounds, but we treat one and all. We collated 148 cases of rabies deaths between JPMC and the Indus Hospital over 10 years. And I'm not showing you the entire list, but not one of these 148 victims were given correct PEP, which is why they died. And of course, the bites were from rabid animals. Over here at the Rabies Prevention and Training Center, we have a very a proper setup with of a rabies clinic where we get proper wound wash, run by the clock for 10 to 15 minutes. We have an adequate supply of a vaccine and immunoglobulin. Each patient is properly assessed about the circumstances of the wound and the depth of the wound, and then treated appropriately according to the circumstances. As for rabies immunoglobulin, we do it properly by weighing the patient, calculating the right amount of RIG, and injecting into each and every wound, whether it is on their arms, legs, face, or anywhere. And we always use the economical intradermal regimen, which is what is recommended by WHO, and we have enough experience in this field. In 2010, the position paper of WHO was that you gave the intradermal injections over 4 weeks on days 0, 3, 7, and 28. But in 2018, this was revised to give it only on days 0, 3, and 7 over 1 week, intradermal regimen. And so it reduced the number of doses and visits from 4 to 3, which is very not only economical for the hospital, but also for patients coming in from distant areas. And he also saved on 0.2 mLs per patient of the vaccine. If you're using the intramuscular, you used 5 vials in up to 2010, and now this is reduced to 4 vials in 2018. And the RIG infiltration at the previous time was to inject all the wounds and inject the remaining intramuscularly. But now that is being deleted. You don't give any rabies immunoglobulin IM, you only inject into the wounds. And this we have been practicing for many years now, but with no compromise on safety and efficacy. Yes, it is much cheaper, but not at the cost of safety and efficacy. Indus Hospital is not only a PEP training initiative, but we conduct workshops, hands-on workshops, and have established at least 10 centers across Sindh. These are up and running. And in 2022, we hope to establish another 5, because this is such a dearth of trained personnel and properly set up centers. I hate to offend your sensibilities, but the public is angry and they demand immediate answers to the local authorities who comply from time to time and perform this hideous, inhumane method of killing dogs, packing them up into garbage trucks and then disposing of them, we don't know where. But, oops, it's gone off.
Has it?
Nice. I think the slides have. Sorry about that. Okay, so we have progressed now to a One Health approach, which acknowledges that the health of a population depends upon the interaction between animal and human diseases in the social and ecological environment. And we are trying now to apply this approach to rabies. Of course, it can happen with any other zoonotic disease, but this is where we have focused. And what has happened is that in December 2015, experts from around the world, donors, veterinary, and public health officials, supported by WHO, OIE, and FAO, adopted a twofold approach and suggested, number one, to deliver proper post-exposure prophylaxis for all rabies endemic areas, and secondly, to scale up large-scale mass dog vaccination along with dog population management. The theory being being that if you vaccinate 70% of stray animals, or all dogs, or even cattle for that matter, but we're looking now at stray dogs. So even if the dog bites another dog, another animal, or livestock, there will be no transmission from dog to people, and so rabies will be eliminated. Who should be doing this work? Actually, it should be dog owners, policymakers, public health officials, city officials, veterinarians, doctors, educators, community and opinion leaders. Everybody should be doing that, meaning it is really the responsibility of the local government and to involve all these other sectors. Nobody was doing it. So we in rabies at the Indus hospital decided to initiate the Rabies Free Pakistan project. We estimated, or we know, that the human population in Karachi alone is more than 20 million. There is no accurate dog count, but an estimated of 200,000 stray dogs and growing every year. In Karachi alone, there are more than 50,000 reported dog bites a year, many more in Sindh, and we are aware of the poor arrangements of solid waste management, which encourages...
Dr. Naseem, I am sorry I have to interrupt, but we are very short of time. Just left with maybe 5 to 6 more minutes.
I have only, just started. Rabia, if you want me to quit over here.
No, ma'am. Actually, there was some time constraints, so I just had to poke in.
All right. Okay. So what we did was that we decided to go ahead with the One Health program, engaged a community in Ibrahim Hedri, which is a fishing village of 250,000 people. We talked to them, engaged them, and they all agreed that yes, dog control and rabies control was an issue. So then we met up with the mayor of Karachi, and he too assented that he would be cooperative and help. And thirdly, I went to the WHO for assistance, met them in different WHO meetings across the world. And what they promised was to send us an animal behaviorist trainer from South Africa, give us animal vaccine, they give us $5,000 and a visit from WHO expert. So here's Mr. Daniel Stewart, who's an animal behaviorist and trainer from South Africa. And he came in here into Ibrahim Hedri, and you can see the delighted crowd watching Daniel. First of all, we had to select the trainers and select people and train them for dog catching, giving them vaccine. We made our own fish nets, collars, and so on. And Daniel taught them how to identify a mildly behaved dog from an aggressive dog. And he trained them on mass dog vaccination, how to catch, inject. We sprayed them with innocuous spray paint so as to identify that they were done. And most importantly, we collected the data in terms of the gender, the age, location. But now we are not using this kind of a collector. We're doing it all on RedCap. It is not enough to just vaccinate, but we also have to reduce the dog population. So we have these two surgical units. One is a stationary container, and this is a mobile van, which are fitted inside like surgical units. And the novice veterinarians from out of city veterinarian colleges were trained by our experts on how to neuter and spay. Here's Daniel. He would catch the dogs with us, bring them over to the surgical unit and get the work. And in January 2018, here we are. Here's the WHO expert who came here, and the boys, the trainers, have all been trained and given their certificates. And we also promote coexistence among humans and animals. We teach children how to not to provoke dogs and get bitten. And then we also went to share our experience of mass dog vaccination and animal birth control with the University of Veterinary and Animal Sciences, UVAS in Lahore in September. And here are some of the results. We have already accomplished MDV and ABC, more than 35,000 vaccinated dogs and more than 10,000 spayed and neutered dogs till the end of 2021. This is not sufficient. You know, after all, if I said there were 200,000 dogs in Karachi, we need much, much more assistance, work from the government, and to progress to our goal. The challenges we've had are numerous. Number one, we had to identify, select, train dog catchers, vets, supervisors, transport the dogs, to get the vans, drivers, fuel, etc. We had to improvise the operation theater with all the equipment and paraphernalia. There was insufficient location for surgeries. After all, where can we go and park our container or our van? Anesthetics, drugs were frequently off the market. We had to repair things. They were vaccinated. And worst of all, many of the vaccinated and even sterilized dogs were poisoned with official sanction. Garbage, broken promises of public-private participation. We need a lot of teams for this. And of course, notwithstanding the very high cost of animal birth control surgeries. But we are not discouraged or disappointed. We've had a lot of successes. More and more people are now aware of dog bites and rabies, especially in Karachi and other large towns and cities. More and more bite victims receive PEP and they are saved from the deadly disease. An important connection came up in 2020 when Getz Pharma partnered with us in the One Health initiative. And this was only entirely an altruistic desire. They do not have any kind of a vaccine to have any other interest. And we proved to the city and the country that MDV and ABC are possible in Pakistan. This has also been taken up as a battle cry in Lahore, Islamabad, and Peshawar. There is a lot of trust between the Ibrahim Hedri community and ourselves. And they're very aware and appreciative of what we have done, although the outcomes of the dog bites and strays will not be apparent for 2 to 3 years. Only then we'll find out how many people, how many fewer people have been bitten or developed rabies, and how many fewer puppies have now come out. We hope that this will work. Other vets and vet colleges are aware. We are now beginning a rabies surveillance to get data from Sindh. WHO, OIE, and FAO have recognized our role, and I am personally a member of the working group 1 in United Against Rabies, which is the tripartite from WHO, OIE, and FAO. Interestingly, I came across this a couple of weeks ago, an ad in the newspaper saying that this is a stray dogs complaint cell, that dogs were not to be killed or poisoned or in any way, and that they will have a program of neutering and vaccinating. And actually, they are supposed to be partnering with us, and we from the RFP are going to be their technical advisors, but this is still in process at this time. Our plan for 22-30 is to scale up the RFP activities in Sindh with priority on small towns and villages, join hands with similar activities in other provinces, partner with local government, we'll get more collars. We plan to set up PEP clinics at government facilities and training government master trainers. We plan to have more publications and get the mortality survey of Sindh. And of course, there are gaps which we will have to fulfill with time. But overall, I want to stress that the ownership of rabies elimination should rest with national and provincial health authorities. The roadmap has been pretty rocky for us, and we've only reached up to 2021 with involvement of UVAS in Lahore. We still need to confirm a formal partnership with local government in Sindh, and we are trying to draw in the Federal Ministry of Health and NIH to join in this project, or it's their business to do it. And finally, I want to say that, this is 2022. We have only 8 more years to complete our purpose.
Sorry, 1 second. Yes.
We're on the last one.
Yeah. Yes, you have to scroll from here.
Yeah.
Okay.
Or just-
Don't touch that.
Okay.
Okay, from here.
Now go down all the way.
Yes, you can move to, not from there.
Not
Yes,
from
you
there,
can
yes.
advance, yes.
So I'm actually on my last almost.
You can let me just place
Yeah.
1 second.
Yeah.
Okay.
Okay. I think I've already gone through that. Sorry about all that.
Yes.
So I was saying that, yes. And I want to give credit to our real heroes, who is the field team. And they work day and night and send us all their data. Every single day they send us pictures of what they have done and the cumulative data. The RFP Indus team deserves a lot of credit. It is a very professional group with epidemiologists, program unit business, and so on. And our partner since 2020 is Getz Pharma, and they have been very useful, they're very helpful, and we also collaborating with animal welfare NGOs. We all need to work together for a rabies-free Pakistan by 2030, and it is as much your responsibility as anyone else's to get this going, to protest, to talk about it, to write about it. But please join in this work together. And although this is not really our domain, but we have done this work beyond the call of our medicine at the TIH. Thank you.
Thank you. Thank you so much, Dr. Naseem. Indeed, it was a very interesting session throughout. Because of the time constraints, I'd just like to wrap up with the comments from our chair and co-chair, Dr. Aziz and Dr. Sumaya. Dr. Sumaya, if you can, or Dr. Aziz, if you can just comment on our session.
Well, thank you, Rabia. Thank you so much. Dr. Aziz, would you like to comment first?
Yes, thank you. Thank you, organizers, for giving us opportunity to get involved in this excellent scientific sessions. I must congratulate Indus Hospital for organizing this very important and scientific session. As we all know that antimicrobial resistance is a global crisis, and millions of patients get infections with MDR pathogens. But unfortunately, at our part, we don't have data, and we don't have attributable mortality to infections with AMR pathogens. What we learned from these all sessions that we are still behind in diagnosing these multi-drug resistant and polydrug resistant bacterial, viral and fungal pathogens. So we need to equip us with these better diagnostic modalities. And regarding the treatment, I can see the questions in the panel that we have nephrotoxic drugs, and few of the treatment options are not available at all. So again, we need to strive, and we need to convince our policymakers to make these treatment options at least available for the needy patients who can afford it. So as we don't have the local data and we don't have the local treatment guidelines as per our resistance pattern, so I must say that we should join hands at least to as I know, our few of centers are generating a very robust data, and based on those data, we can have a local guideline, at least with the available options, what can be used for treatment of these AMR pathogens, because different institutes, there's a different practice. So if we can come to a consensus and develop a good treatment protocol guideline, and we can also insist to policymakers to make the other options available, this will be a good help to combat this difficult, challenging AMR pathogens treatment. Thank you very much.
Thank you so much, Dr. Aziz. Now, Dr. Sumaya, last comments.
Yes. Yeah, thank you, Rabia. So, just wrapping this up because obviously we are short of time, I would definitely like to thank all the speakers on behalf of the Indus Hospital and the Medical Microbiology and Infectious Disease Society of Pakistan. Dr. Juzar's presentation was extremely engaging, and Dr. Naseem, it is always a pleasure to hear you speak on rabies, which is obviously a very highly neglected topic and needs immediate and effective attention from the relevant authorities. So, thank you very much. Thank you to all the attendees, and please stay back to attend the remaining sessions. Thank you.
Okay. Thank you. We have just one question for Dr. Juzar Ali if he is online.
Yes, I am online.
This would be the last. Okay, thank you. So the question is that how long to treat disseminated subcutaneous NTM infection recurrence? Recurrence of disseminated subcutaneous NTM infections. How long to treat that?
That all depends on the underlying conditions and the cause thereof. Are there any other comorbidities? Are there any other immune deficiencies or states that need to be resolved? The treatment essentially can be as long as almost 18 months. So there's no clear-cut guidelines on the duration of therapy. It actually depends on the culture conversion and what your culture criteria are. And so the answer to that is a little hedgy, but it is that it's a long-term treatment and can be up to 18 months, if not less.
Okay, okay. Thank you. Thank you, sir. Thank you so much, everyone, for joining us. We're concluding our session. I hope you enjoyed and learned from our ID session. Thank you so much.